Our next speaker is Dr. Peter Fisher. He's from Virginia Beach, Virginia, and he's going to be speaking on state-of-the-art diagnosis and treatment of common rabbit diseases.
Thank you. Thank you, Margaret. Can you hear me okay? Is it okay? Okay. So I think this conference has done a very good job of intermingling the different speakers and topics, and we overlap just a little bit, but you get different perspectives, but you also get a refresher on some of the things, and additional information. Each person has something additional to add to the topic. Okay, so I'm going to take a look at some familiar diseases with an emphasis on some insights gained through case studies in my own practice, retrospective studies where researchers or clinicians have looked at 13 cases and summarized what they found from those cases over the years. So that's what retrospective studies are, or original research. And I'm going to tie that all in with the more common and also less common diseases that we do see in the house rabbit. So let's start with GI disease. We did talk about GI stasis quite a bit, so I will go through this part a little bit more rapidly. So again, we all know hay 24/7. No one needs to know about, be educated on that aspect. We know about the pellets, the greens, and hay. But again, I'll emphasize with GI disease, don't give them the omnivore's dilemma. Who's read that book, Omnivore's Dilemma? It's quite an interesting take on nutrition in America, or options we have. But we really, when the rabbit, again, they're selective feeders, and when if you give them this choice, many times they're going to not look this way towards the hay, but actually looking towards the more treaty things over here, the sweets and things, and they may binge on those, and that may lead to some problems. So don't allow that to happen in the first place. So let's get a couple of definitions of GI stasis, and this is from the literature. The first one is from Francis Harcourt Brown from the UK. GI stasis is triggered by an adrenergic response to pain or stress that is characterized by anorexia and absent fecal output. So stress or pain, underlying cause for this disease. And the second one from Angela Lennox in Indianapolis, rapid gastrointestinal stasis syndrome, which she likes to call RGISS, is a complex group of presentations with multiple primary and secondary etiologies. So there's multiple causes for this disease, not just one cause. So we're talking about trying to make a diagnosis. We want to find out why does this animal have GI stasis in the first place. And we all know that a certain number of rabbits are repeat offenders, that they tend to get GI stasis recurrently. So we did look at why is this happening. So we talked a little bit about inappropriate diet, things that are high carbohydrates that can mess bacterial flora up within the cecum that Micah alluded to earlier. Anything causing stress or pain. So in any case of GI stasis, we need to look at the mouth. Is there dental pain? And during the physical exam, do we find any other sources of pain or any other diseases that may be causing this in the first place? Again, any other diseases may cause this imbalance. So, what do we see when these animals are presented, or what kind of information are you giving the veterinarian about the patient when you bring them in? You can say that he's usually not eating. There's small poops, and as in this case, you can just see the tiny little poops right there, or there's no stools at all. They may be inactive and depressed, and they also may be hunched and grinding their teeth. We heard someone talk about the crunch of the teeth. That was indicating abdominal pain in many cases. And they may be gassy. You may be able to palpate them. You guys are adept at knowing what your rabbit's abdomens feel like, and you may be able to feel that gas or hear that gas making noise. And also, if you're adept at palpation, you may feel that doughy stomach, the stomach that's kind of full of a wad of food, perhaps with some hair. So when I do my physical exam, part of I mentioned palpating the stomach. I feel up underneath the rib cage, and I feel for the stomach and how firm is that, how big is it, do they have bloat? We're going to talk about differentiating bloat or obstruction from routine stasis. How big and dilated that stomach. Does it feel like a water balloon, or does it feel like something that I can really compress and massage and break down some of that wad of hay and fur and ingesta. And I also listen with my stethoscope, which I'm doing here. So I listen to gut sounds. Are they overactive? If they're really active, it can indicate just irritation. Or if they're normal, you can hear that little tinkling sound, whether the gut sounds every 20 seconds to 30 seconds, and that is more normal. Or are there no sounds? And no signs is not a good sign, because that means the gut's dead or slowed down. It's just not moving, and not a good sign. Also, we're going to, again, as I mentioned, look for underlying evidence of dental disease. So when it comes to diagnostics, we've talked about blood work, we've talked about imaging, and in my practice, if I have a choice, if someone's going to give me a choice, I have so much money to spend, most of the time I'm going to go to imaging or radiology over blood work, because really I think it gives me more information. So when it comes to, and we'll see that as we go through this lecture. So this is the more normal. We've seen these films already, and you have a cecum full of food. This is a GI is full of ingesta. We have little fecal pellets up in the colon here. We have a stomach here that's a little bit of gas. This is some gas, but that's all normal. The dark is gas, and then a stomach up here, and it's normal. Oh, you can't see it? It's tiny, isn't it? Okay, I'll point my fingers from now on. Thank you. So again, cecum in this area, there's little poops in the colon there, and there's normal stomach here, and then here's your heart and lungs here. Versus something like here, you can appreciate the difference that there is no ingesta here. So it's empty. There's kidneys here, some normal calcium in the bladder here, and then a stomach here that has that dehydrated mass of ingesta, maybe mixed with some fur and things. So, and then lastly, we'll look at this one first. This one is much increased gas. So all this dark is gas. You can see these folds in the cecum that was alluded to in Micah's lecture, and all the dark is gas. And this guy is obviously uncomfortable and painful. So you get a lot of information from your radiographs on how to handle that. So one of the first things, look at that last x-ray, one of the first things I'm going to do, if this animal seems painful to me, I'm going to say, let me go get this guy something to make him more comfortable. Let me go get an injection of an analgesic or pain medication. Because before we even go further into the history gathering and talking about what's going on, I want this guy to feel more comfortable. So we talk about analgesics and we talk about opioids, of which buprenorphine is a common one, and then of course meloxicam, which we're going to talk about in more detail. I use both of these, and together you can use multimodal analgesia, which means more than one type of analgesic to cover different areas of pain. So this particular article, which was from the American Journal of Vet Research, we were talking about meloxicam and the controversy of how much do we give. And this was from the Kansas State, Dr. Jim Carpenter's lab, and it was a 2013 paper. And he looked at oral administration in single and multiple doses. And the authors concluded that a dose of 1 milligram per kilogram given once daily may be necessary to achieve clinically effective circulating concentrations of meloxicam in rabbits. Now, this paper did do the pharmacokinetics, which means they measured the amount of meloxicam that was in the bloodstream of these animals at varying dosages, and they came up with this 1 milligram per kilogram based on what we know about the cat and dog literature. Again, we already said that rabbits are not cat and dogs, but it's better than before. We would basically take the doses from the cat and dog formulary and then empirically somehow think how we're going to use these in rabbits. And many times it's the same exact dose that we use in these animals. And we didn't really know whether or not these were giving accurate and good enough blood levels. Yes?
I have a question. Was this study done with rabbits who were healthy?
Yes.
Okay, so my interest is what happens when a rabbit has a static gut, an digestive filled belly, and is not metabolizing stomach contents normally, we're shoving Medicaid down the top. How much is that going to affect pharmacokinetics?
So certainly, the question is how much is it going to affect when these animals are sick and they have stasis and the gut's not moving, and therefore you put the meloxicam in the stomach and it's just sitting there, correct? So that study has not been done, and that's again where multimodal analgesia will come in, because you're not only treating it with one drug, naloxone, which comes in an injection, so you can start with an injection, number one, and you can also use buprenorphine with it, so you're treating pain in two ways. So we don't start with the oral drugs right away. We give an injection to get them started.
No, I asked that because a lot of, I don't know what other chapters, I'll speak now later. I don't know what other chapters are doing, but in our chapter, a lot of vets try to have an agreement with clients. They send the client home with enough Metapam to keep at home in case.
So these are for recurrent bunny, but multiple bunny households, and they want to have it on hand.
The bunny goes into stasis, and the owner decides to start giving Metapam to a gut that's not moving. And I'm just wondering what your opinion is of that.
The studies haven't been done. I'm hoping that it does. Some is absorbed from the stomach, but again, it's not moving, it's not ideal, but that's why you should take them to the veterinarian the next day, as Donna said, with her emergency therapy lecture. You know, you're trying to get them through the night, or if it's a Sunday, through the day and night, until you can get them to your veterinarian the next time they're available. So the bottom line, I don't really know the exact answer to your question.
Does that fall under the won't hurt but might help?
Yeah, I mean, I don't think it's going to hurt. I mean, we're using more and more meloxicam, obviously, in rabbits. And let me just go to this slide first, and then I'll say what I was going to say. So, long-term, what about long-term use? That's important because some animals are in, whether they're older and have arthritis or for whatever reason have chronic pain disease, need to be on something for long-term pain control. So, the Jim Carpenter's lab did another study looking at using this same dose of meloxicam, the 1 milligram per kilogram, because everyone, like, I remember on yesterday when someone mentioned 0.5 milligram per kilogram, people were, like, that was a high dose. Well, this is twice that, obviously. So what's the safety of that when it's used long term? And that's what everyone was wondering in their heads. So Dr. Carpenter's lab actually did this. This was presented at the conference of the Association of Exotic Mammal Vets last year in Indianapolis. So this was a 29-day study, at that 1 milligram per kilogram dose, no gross or histologic lesions relating to meloxicam were identified, and all values on biochemistry analysis, so your blood work, remain within normal limits. So it seemed to be safe. You know, they always say maybe. They don't say are. It's always may be safe. But that's really important information. You know, number one, many of the veterinarians that read this information started increasing the dose of meloxicam in the rabbit. Now, do you do that forever? Now, even in dogs and cats, not cats, we don't use meloxicam in cats that much long term, or at all long term, but in dogs we do, and you can titrate it down. So in other words, you can start at the prescribed dose, and if he's uncomfortable, we tell the owner, start dropping it a little bit every 5 days or so and see if you can see a difference in the amount of comfort your pet is experiencing. And if it gets to the point where you go down to the point where he seems more comfortable, then go back up to the last level where he was comfortable. So I would say the same thing would be true of the rabbit. If you're using 1 milligram per kilogram for 29 days, which is shown to be safe, and I've used it longer in rabbits, really, and not had a problem. But you could always start dropping down to 0.7 and then go down to 0.5 and see if you're getting the same effect, fine. If it seems like, no, he's not as active, not jumping up on things like he is, not as happy as he was, then bump it back up. So that's what I would suggest. Okay, so prokinetics. George alluded to metoclopramide and cisapride. I put a question mark by metoclopramide because in veterinary medicine, as far as dogs and cats, we don't use it very much anymore at all. Different drugs have come to replace that because we don't think it doesn't last as long as we want it to. It just more localized to the stomach when we really want more caudal, GI movement. So we work more with cisapride, and cisapride was taken off the human market because of the cardiac effects. So you have to have it compounded. So you have to get it from the compounding pharmacy. And again, as we know, no drugs are approved for the use in the rabbits. All this is off-label, and they're trying to make it more difficult for us getting compounding drugs to use in these animals, that we have to only dispense enough until they can get it from the compounding pharmacy, which then adds the expense to the owner. So it's controversy in the industry, let's say. So I do use prokinetics definitely with these guys to get the GI moving. That's what a prokinetic is. Appetite stimulants. I'm a big believer in the use of cyproheptadine. Empirically, again, 1 milligram per kilogram every 12 hours orally to stimulate the appetite. Because we know if we can get them eating again, get the gut moving again, that they will have a better chance of getting more fiber, more movement, basically. And control gas, I meant to go and question mark that, how much that works. Donna seems to think it helped in her situation to break those big gas pockets down and get them to be able to move that gas on through. But I really encourage exercise. So if you make them more comfortable with pain control and you encourage them to move, just like us, what happens when we go up the stairs and we have gas? Yes, we know. It moves. It comes out. So, same thing with the bunnies. Get them to move. You can't. Walking around a colicky horse, over and over to get the gas to move in the colicky horse. Another analogy. So, and abdominal massage. I'm a big fan of abdominal massage. Be finished here and I'll get to your question. So, I remember when I was newer at rabbit medicine, I had this rabbit come in with this huge stomach, and I thought I had, beef, fur ball in the stomach, gastric hair ball. And I palpated its stomach, we gave it sub-Q fluids, and I can't remember what else, but it came back the next day, I was going to have surgery, and I palpated its stomach, and it was gone. I mean, that had the fluids and whatever else I did along with the massage made a big difference getting that to move. So I'm a big believer if you feel comfortable, I can teach the owners to try to massage the stomach too. But I'm actually getting up there and feeling that stomach and breaking that wad of ingest down a little bit. Question?
So, I am a believer in exercise. I've watched one of my buddies chase her companion around, seems grouchy, not to the water on the bin, and that's the first time I've heard a rabbit fart. My question goes to the idea that this is all connected, right? All of the muscles are moving, and you get that pumping action in the legs, that can encourage the peristalsis. And similarly, this is where the question comes in. If you have a rabbit that will start eating with the restriction just right, is it plausible that that same kind of eating motion, even though they're not actually eating anything, but it's still in the same way, but you're uncomfortable moving around?
So the question is if you get them to sort of kiss you and
well, but somebody's will lick if you
But the thing is that takes a stimulation to get the gut moving. I don't have an exact answer to that. I can't see why it would not help in some respects, but I don't have a precise answer that's been studied or done. But I do think fluid therapy is an extremely important part of the therapy for GI stasis. And you want to get the gut moving again, and if a gut's dehydrated, it's not going to move. Another question?
Does cyproheptadine, is it 1 milligram per kilogram?
Yes.
1 milligram per rabbit?
Per kilogram.
Because on there it's a rabbit.
Was it say rabbit?
Yeah.
Okay. Then maybe it is. Believe what my slide says, okay?
On the abdominal massage, how do you know how much to do without possibly injuring it?
So the question is, how firmly can you massage this abdomen? So it's fairly gentle for the most part, but in the stomach, it's a little bit firmer. So back in the bladder part, I may be more gentle, but when I get the ribcage, who here has felt the rabbit's stomach? Okay, so most of you have felt the rabbit's stomach. You know what I'm talking about. So you can press on it so it indents, let's say. You can, make a difference. Don't just go, doing a little bit of this is not going to do. You have to really get it so it indents, and so you feel like you're breaking that down a little bit. I've never had one where I've created a problem. Now, it's different from bloat or obstruction. We'll see. You just can't do that. You don't want, it's like a water balloon. So the question then becomes, do you do sub-Q or IV therapy? So that all depends on the grade of GI stasis it is. So I carry greens in my office all the time, and if somebody comes in and says, my rabbit's not eating, he's not pooping, and while they're having this, I'm having my discussion, I ask my assistant to go grab some greens, and I just put them on the table, and I see what the rabbit does with them. The rabbit just sits there and is not happy, not doing anything with the greens, and I know he's pretty sick. Now, if he looks over at the greens and has some interest and even starts eating them, I know he's going to be an outpatient case. But again, not everybody can afford inpatient care and IV fluid therapy, but certain cases do need that. And again, assist feeding. So we all are familiar with the critical care. Lefebvre also makes an emerade herbivore that you can syringe feed to the rabbits. Or you can also use a nasoesophageal tube or nasogastric tube. Really ends in these, they're called NG tubes, they really do end in the distal esophagus. So that was already covered by Avery, but the critical care in the fine grind can go through a fairly small, we call them 5 French, is a small size tube, and it has been shown to go through there, and I've used it to go through a tube that small without clogging it. And correct your underlying dietary problems. So when you go home with the rabbits, you're sending them home, you need to have that talk. What are you going to be feeding this rabbit going forward? And what are you going to, you want, if you won't eat, there are a certain number of rabbits, they always say to me, he won't eat hay. And we have had some tips on getting your rabbit to eat hay, and I know you all have your own little tips for getting those rabbits to eat hay, and I don't have any magic wand for that. But treats, again, use healthy treats versus the high sugar treats. And patience, people will call me back and say, he's not defecating, it's 2 days down the road, he's not defecating, still haven't seen any poops. What do? I ask, has he been eating? Oh yeah, he's eating. Then I say, be patient, because eventually, it's going to have to take its time to work its way down for that secret to fill back up and for the stools to start being produced and passed again. So other options, I know George alluded to cimetidine, Zantac, or he reduced cimetidine is, what's cimetidine on the market? It's Tagamet, right? This is another antacid, ranitidine, and that has also been shown to synergistically help cisapride work as a prokinetic. And if we use more meloxicam, I did have veterinary, I had a colleague that commented, we didn't see as many GI ulcers or stomach ulcers as we did until we started using meloxicam more. So it's not necessarily a benign drug, and any NSAID can create GI ulceration. So the bottom line is we do have to be careful and observing. And sometimes if you're going to be using it long term, you may want to add an antacid in. And again, Zantac or ranitidine has been shown to synergistically help cisapride perform as a prokinetic. And then domperidone or metilium, it's an antidopaminergic prokinetic. It stimulates, again, bowel movement. It's not approved in the United States, though it's in Canada and Europe, but compounding pharmacies, somehow, I don't know how they get it, but they can get it for you, yes.
Are they using that in rabbits now?
Yes, in Europe they are.
Okay.
And anybody had any experience with that here?
Yes, in myself, but.
Personal experience.
Yeah, I was calculating but I didn't really use the rabbits, but I can get some comments.
Yeah, through a compounding pharmacy. So it's something to consider. I read about it in a journal that somebody in Europe was using it, so I was wondering if anybody had that. So it's not something on everyone's radar here that's not online, so not something I'm missing. You think it will show? So it won't because of cisapride's problem.
No, I'm saying it doesn't have cisapride's problem. I anticipate it will end up in the United States shortly.
It's not less side effects, it doesn't cross the blood-brain barrier, so.
Yeah.
Did everyone hear those comments? So George said that it doesn't have the side effects of cisapride, so he's anticipating that it will arrive in the United States soon enough, and that he's interested to see what will happen with the rabbit when we start using it. Okay, so versus this case, so here's another rabbit that comes in. This is the one I felt, and I go, this isn't good. It's really not looking good, number one, when he comes in, and I feel his stomach, and it's big, tight. I mean, look how big this stomach is right here. This is all stomach, and that's a gas pocket on this. So you can stick your hand in it. Normally the stomach should be here, and you just stick your hand underneath the rib cage, the ribs right here to feel it. But this, you just feel the abdomen, you feel this water balloon there, and it's tight, and it's uncomfortable, and it hurts. So that is a case where you have to think, I want to take an x-ray on this animal because that's what I felt, and this is what I'm finding. Again, there, empty GI, nothing's in it, he's sick. So he's going to get his immediate injection of analgesic so he's more comfortable, and then we got to talk the talk. Because these animals can come in, and this one with that, and this one died shortly there. I mean, he rested, about 30 minutes after being in the office. He just arrested, and this is what all came out his nose and mouth. And when I did a necropsy, as we've said, they have the cicatrove with hair that's a little bit bigger than most cicatroves, and they can get stuck in the small loops of bowel, most commonly in the proximal duodenum, which is the proximal small intestine, or at the ileocecal-colic junction, so right where the small intestine empties into the hindgut. The very end of the foregut is where it meets the hindgut. So those are the two places it tends to block. And if it does get a blockage, we'll get to that. So again, good question, yes?
Yeah, was the owner able to tell you how long that rabbit had been symptomatic, that they noticed any behavior?
It was from a rescue that was not as well managed as some, and probably they weren't as observant. So I didn't have the answer on this one. But longer than most of my clients bring, and that's the only one I've ever had that, arrested that quickly after coming in. Yes?
This one is not bloated, just a little bit further down, and we had got past the pyloric valve where it was blocked. Is that why this did not blow through?
Well, I always call it GI obstruction versus bloat. I mean, bloat for me is gas, strictly gas, and so I know some people have alluded to it as being bloat. But Caroline, do you have a comment on what you do? Do you differentiate obstruction with fluid versus bloat with gas, or do you?
I think he's bloated, and I think possibly because it's a GI obstruction, so it's.
But you can see, I mean, in guinea pigs certainly we see bloats, they're strictly more like the gastric torsion. In dogs that was alluded to, it's air. And I see these more common. I rarely see a rabbit that's full of this air.
I guess I should call it gastric tympany.
Yeah, that's probably a bloat is, we sort of think of bloat with gas. And it's, again, semantics, but it's a big stomach. So tympany meaning one that's large and distended like that. So the question is, when do we take these guys to surgery? Because we all know that a certain number of very sick rabbits that we take to surgery are not going to survive. So when's the question that we make that suggestion for that person who's willing to go all the way? So, number one, monitoring serial radiographs, so watching them over the next 24 hours, because you can't give it too much time. If it's not moving, they need to be cut. But you do want to rehydrate them and give them supportive care so that when we do take them to surgery, they're in the best shape possible. You can also look at a CBC, look at the white cell count. If it's elevated, a neutrophilia, high number of circulating cells that goes along with inflammation and infection. If that's higher, that can indicate that there's inflammation, this type of inflammation associated with this gut. You can see the hemorrhage there. That could cause you neutrophilia and make you think more weight to support cutting this in with this obstruction. And then blood glucose level. So you may ask, why don't you do barium series? So who knows why we don't do barium series, or we do, but why it doesn't work so well in rabbits, a barium series. It's always full, number one, and the GI motility is very slow to begin with. So in a ferret, when they ingest something, it takes 3 to 4 hours to hit from the stomach to the colon. In the rabbit, that can take 3 to 4 days. So you don't have that type of time to wait for it to see if, and if it's not moving, you know if it's not moving it's because it's depressed or because it's obstructed, so it doesn't help that much. But this new paper, or this paper from Francis Harcourt Brown looking at blood glucose levels was fascinating. So this was from the Veterinary Record, which is the UK edition of our American Veterinary Medical Journal, 2012. And Francis Harcourt Brown and her son did a study looking at the clinical value of blood glucose measurement in pet rabbit health. And this was a 907 rabbit study. Now, this is not just looking at GI disease, but looking at blood glucose in rabbits in general for any type of illness across the board, and healthy rabbits as well. But what she did find when we're talking about GI disease was that severe hyperglycemia or high blood glucose levels are associated with a condition with a poor prognosis, a more severe condition. And rabbits with confirmed obstruction had a mean blood glucose of 445, here's your normal, 108 to 160, versus rabbits with stasis, which had a mean blood glucose of 153. So you could run a blood glucose, and if it was really high, you could say, you have a high white count, and the rabbits take serial x-rays, which we're going to see a case in a minute. That could all give you enough information to say we need to cut this rabbit.
So are they partially insulin resistant, or is that just a stress response?
I think it's more of a stress response, but I don't have a precise answer for that. There you are.
Flipping over because they've been.
I mean, they are stressed animals, so it's a good question. I don't know how much of a stress response, because they're already stressed anyway. And so you'd think that they would have higher blood glucoses with any stress, like cats. Cats stress easily, and we don't, when a normal cat should be 80 to 110, well, we look at a cat that at 160, 180, we don't really worry about it. When it gets over 200, then we worry about diabetes. Now we know that rabbits just don't get diabetes. I mean, rare at all. So what is the cause of insulin resistance when they're not responding to insulin? I don't have the pathophysiology behind that.
Yeah, and I'm not suggesting that they're like metabolic syndrome or something. What I'm wondering is if there's something in their stress system that's causing either some sort of inflammatory or inflammatory-like response, cortisol-related, that's creating a partial insulin sensitivity that maybe has been going on for a couple days.
Good thought.
But, yeah,
I don't have the
I can
answer.
make up all sorts of excuses.
But the bottom line is that that's what the higher hyperglycemia. Now they just found this is fairly recent, 2012, and I didn't know about this paper really until 6 months ago. And I think that now they've done this. I have to go back and reread to see if they really theorized as to why. But that may be what's done next. You know, many times we start these papers and we find one thing out, then at least another paper that needs to find out why, let's say. So this is Amelia. She's a 3-year-old female spayed. They came in on the, I think it was the Tuesday before Thanksgiving last year. And she had that x-ray was from her, and she wasn't feeling well. And this is here when she's being treated. She has her IV fluids. They were giving her all the therapies we talked about already. And we're trying to decide, do we cut this rabbit or not? So this was her original x-ray here, and you can see the big stomach, little gas in the colon. She's uncomfortable. She has things we've already talked about for GI disease. And that night, Tuesday night, went ahead and pulled out, sedated her, and we have a nose cone on giving her the sevoflurane, and I passed a river tube. I said, I'm going to try just get some of that Ingesta out there to give her a better chance for this to give her more comfortable and see what happens. And it was pretty liquidy. It wasn't all dried out. And I got a lot out, and the next day, took another x-ray. So here, what a difference. I mean, this is day 1, and this is day 2. And just look there, you know, this is, now you can actually see we got rid of the fluid, and you can see some ingestion. I mean, the stomach, the gas has moved, and so that's a good sign, and she was feeling a little better. And she actually was eating a little bit. So I said, we're going to wait on this one. We're not going to cut this one. And she continued to go on and respond to medical therapy. She has since, she's been a repeat offender, and I was interested whether, you know, she has some English spot gene going on, you know, that's making her be a repeat offender. So to close out with the GI disease, you know, cephal dysbiosis, the bacterial overgrowth, this has been covered, you know, pretty well in the lectures so far. But again, many times an enterotoxemia, and it may not be, this one has diarrhea, and that's not common. More likely, or more commonly, you see these wads of mucus coming out of the colon or some stool with lots of mucus in the covering that. And the causes can be increased carbohydrate exposure, like the treats and things like that, yogurt treats or anything, simple carbohydrate, the cookies the rabbit stolen, or you know, the mueslis that they pick out selectively, the high carbohydrate, high sugar containing items. And those will feed the unfriendly bacteria, the Clostridium. They're normal and they're natural in the gut. E. coli is normal and natural in the gut, but at low numbers. And this just feeds them and makes them overpopulate. So the poor Bacteroides is then overwhelmed by these Clostridium, and the body becomes overwhelmed. It also, these increased carbohydrates will suppress motilin. Motilin is an enzyme that stimulates GI motility in the small intestine, and when you give excess carbohydrates, it will suppress that motilin. Another reason why it can create this problem. And then, of course, we all know that the oral beta-lactams are a problem. But still, occasionally somebody, you know, you get an animal that comes in and somebody has dispensed oral beta-lactams. So they produce these toxins, the ototoxin that was alluded to. And so we want to treat them with mostly, you know, so again, all these sick animals need IV fluids, you know. That's a hallmark of maintaining blood pressure, rehydrating tissues, making them feel better. That's important. dietary change to high fiber, but it's once you get them to survive. Now, metronidazole is an antibiotic that will kill Clostridium, so if I do cytology, meaning I roll out some of that stool on a slide and stain it, and I'm seeing lots of Clostridium, sometimes I'll add in metronidazole. And then Questran, you probably used the cholestyramine, many of you here, and that all comes from one paper that said it worked in one rabbit, and then it gets perpetuated into the next paper, the next paper. You know, how many people have used that here to feel like it works? So not very many handfuls. Some handfuls that feel like it works. And then trichotrophic transformation of gut flora. So again, giving them secretosis from a healthy rabbit and then an ingestion and then tubing it into the sick rabbit to repopulate the gut with more normal flora versus a probiotic. And I am on the same page as everybody else, or not, that my gut was about probiotics. I don't really use them because I don't know. We don't know what they really what they're doing. You know, is the bacteria within them surviving that low pH in the stomach? Are they making it back to the kind gut where they're needed? So again, the research is going to be done about looking at what is the normal flora, and that's what they did in dogs and found, you know, which bacteria are normal, which ones are friendly, which ones survive to get down to the latter part of the gut where they belong. And those are the ones you choose to use in your probiotic. And that work just has not been done in the rabbit. But this drug, this ditrioctahedrosmectite, is a clay mineral that is used from the, I got this from the horse literature. So again, they have a big cecum. They're not exactly like the rabbit, but sometimes it's probably more of the horse literature is appropriate when it comes to the gastrointestinal tract for the rabbit than the dog literature. But they use this in a study looking at toxins produced by Clostridium perfringens and found that it worked. And I've had, how many people have used that here? So sprinkling, and what do you think? Works. That's what I've heard before. It works. Works great. Hard for them to get it to take it. Doesn't taste good. But something to consider. Okay, so let's look at Coco. So Coco was a 10-year-old female spayed Dutch that I came in. First thing, I worked 1 to 7 on Tuesdays and Thursdays. I got there at noon, and she says, this woman just called, the hospital just called, and this rabbit's there, and they want to send her over. It's really sick. I said, fine. Come right now. So she showed up, and the rabbit, me, he's like, you know, it's not big, trying to breathe through his nose, but they're all good nasal breathers. And you can't really see very well right here, but his nose was crusted with nasal discharge, and I felt his stomach, and he was uncomfortable. And so I said, and you can see he's been a little unkept there with the fur. I said, let's go ahead and take an x-ray. He had his analgesic, I took an x-ray, and this is what I found. So, it does have some ingestion in the stomach, but gas galore. It's uncomfortable, gas galore. These are clips from the spay, and what's this? Bladder stone, right. So he's got bladder stone, GI stasis, respiratory disease. So you look at his lungs, he's got a little bit of pneumonia going on. So I said, you know, you have to, are you in it for the long term? You know, this is going to be, if we want to turn this guy around, it's not going to be cheap. We got to go all for it because he's got 2 diseases that could really kill him, and one that's going to complicate things a little bit. But you know, she was all for it, and I said, let's go. So we I need to go slow. I need to go slow with this rabbit. I'm going to get the gut going and cleared up first. We'll start working on the respiratory disease. We'll worry about the bladder stone later. Let's cover these first two problems first. So fluid therapy, antibiotics, both systemically and via nebulization, which we'll talk about, and nutritional support. Luckily, he really liked the critical care office when he ate it. So that's always is nice when they do that, isn't it? Makes your life much easier. And of course, pain management. So he was helping us along with all this, which was nice. But here you go, and this is after it's even been cleaned up. I mean, it was just caked on there. And you know, it hurt, and I peel a little bit off at a time and soak it. But, so before I talk about what we did next with him, I just want to talk about, you know, what do you do about chronic offenders when they have this respiratory disease? We've all had them. Culture, again, I'm a big believer in culture. Someone said, well, you don't get anything out of them. Well, you may or you may not. It's a gamble. You know, you may not get what you're expecting. And one of the reasons is, you know, let me move on. I'll come back to one of the reasons. But again, they have to be out because it hurts to stick something up your nose like that. So they have to be anesthetized or sedated. So let's look at this paper. So this paper out of Veterinary Microbiology from 2006 looked at the epidemiology and susceptibility of pathogenic bacteria responsible for upper respiratory tract infections in pet rabbits. So basically, this is a culture microbiology journal. So they're looking at the culture results from these deep nasal cultures in rabbits. So not surprising, Pasteurella multocida 54.8%, but right behind it is Bordetella bronchoseptica, and then right behind that Pseudomonas and then Staph. So they also found that many times there was not just one of these, but several of them. So they grew up both a Pseudomonas and a Bordetella, something like that. And so say you had a not so severe infection, you cultured out, you grew nothing. What could that tell you? Well, it may be Pasteurella. Pasteurella is fastidious, which means it doesn't live long outside the body, and by the time you put it in the culture tube and get it to the lab, and the lab sets it up, it may not have survived that transport situation. So that may be why your culture comes back negative. But it does tell you something. It may tell you may not have these other bad bacteria. But the study also looked at antibiotic usage with us. What's susceptibility of these organisms to different antibiotics? And what they found was that marbofloxacin was a good oral choice, and that marbofloxacin is a quinolone like the enrofloxacin, which Baytril is, and the ciprofloxacin, and it showed that marbofloxacin was a good choice for these bugs. And sometimes genticin, but genticin is an injectable. They mentioned genticin, but we use more amikacin. Those two drugs, genticin and amikacin, are aminoglycosides, and they only come in injections and have their own problems. But I do use them with nebulization, which we're going to show in a minute. So marbofloxacin, which is Zenequin, if you ever have your dogs and cats and you know what Zenequin is by Zoetis, only comes in pill form, so you have to have it compounded. Administered orally every 24 hours for 10 days, appeared to be absorbed well and tolerated by rabbits. A dosage of 5 mg per kilogram per us every 24 is recommended for rabbits to control infections attributable to susceptible bacteria. So again, the work's being done slowly and surely on different antibiotics. So it's good news. And the same thing with this particular antibiotic, orvofloxacin, another quinolone. This was presented by Matt Johnston, that was mentioned from CSU in Colorado. Pharmacokinetics and oral bioavailability of orvofloxacin in New Zealand whites, and it's going to come out in our research journal sometime in the next year or two. But this showed that fluoroquinolone antibiotics are widely used, well, we know that in rabbits, enrofloxacin, Baytril, we all know that, we've all used that for years. But this study evaluated the pharmacokinetics and oral bioavailability of orvofloxacin, which is available to us in a suspension already, approved for dog and cat medicine. But you don't have to have it compounded. It's a nice thing. And they showed that they looked at 2 different doses, 10 and 20 milligram per kilogram once daily in New Zealand whites. And most of the time he felt that I just communicated a personal communication with Matt this week. He said, what's he using now? This paper really didn't make that clear. And he thinks that 10 milligram per kilogram in most cases is just fine. Now, I've gone up to as much as 20 in those cases that have been stubborn infections. I've gone up to 20 milligram per kilogram, and when I've had a real bad infection going on. But again, it's another antibiotic that we have that we've done work on. Question?
I have a foster who was on Zenequin long term for an abscess. Now they've been on for a couple of years, and I used mortar and pestle.
Mortar and pestle, and you?
And you put it in the syrup, so the pills are stable, and they're much cheaper.
So the comment was that he had the Zenequin pill and crushed it and mixed it in a solution and gave it orally, and I've done that too.
I've had a large number of rabbits that you put it in a raisin and then you hand it to them and they eat it.
As long as you're not giving him 10 raisins. Just one. Okay. So,
Through multiple confiscations with URIs, what we've learned, trial and error, is that the antibiotics will not work
And certainly, everyone heard that comment about sanitation, making sure you clean water bowls, etc. with the And also, you know, it doesn't mean everybody's water bowl, when you have multiple water bowls you're cleaning, goes back with the same rabbit, so it can then go on to another rabbit and infect that rabbit. So, great comment, thank you. So, back to nebulization. So here we are back to Coco. No, yeah, Coco. Romeo's her last name, so I always want to call him Romeo, because their last name is Romeo. But you can see is, you know, he's getting nebulization therapy. So he's getting multimodal antibiotics. He's getting oral antibiotic. He's getting nebulization. I'm using amication, aminoglycoside in this. And he was having these sessions 2 or 3 times a day. And so here's Coco now with Mom's beautiful daughter. And so at this point, the bladder stone is still there. You know, she's kind of tapped out, you know, financially on this case, and we're managing that with some long-term pain control. And I've talked about, you know, if she's doing so well, she just hates to take him to surgery. So we're kind of living with that right now. But of course, that kind of switches over to the topic of calculi. Obviously, we're going to take a lot of these to surgery because that's the only problem they have. So, you know, we have this rabbit that comes in that has this nasty perineum, soiled perineum, and you, your job, my job, is to figure out why this is. So what am I going to do? What's my #1 diagnostic? That's a hint. Radiograph, right. So here you can see this one actually has urethral calculi. So not bladder calculi, but calculi that have gotten stuck in the urethra, which is the duct from the bladder to the outside. And that's causing all this oozing of urine and soiling of that fine fur and causing the dermatitis that occurs. Now, this particular client couldn't afford to hospitalize, couldn't afford to do surgery, so I treated it symptomatically with antibiotics, clipped and cleaned antibiotics locally, as well. My favorite topical antibiotic is silverdine, silver sulfadiazine. In rabbits, we use lots of that. And I had done, looked and found bacteria in the, it was hard again, his bladder was empty, so I didn't have a urine sample from the bladder, which would be an idea, but it was obviously infections that need antibiotics. Whether it was in the bladder or not, didn't matter. But he's getting antibiotics. Fluid therapy sub-Q, went home with nutritional support, analgesia, and it's just a higher magnification picture. You can see again those stones back there. And I said, well, I want to see you back in 10 days to see what's happening. You know, are these stones still there? What's happening? So 10 days later, this looks a lot better, obviously. So I took my radiograph, and I was so happy. Yes, they're gone! So he had, you know, some analgesia, treating the infection, maybe relaxing, pushed those out, and they passed on their own. So it's just that can happen. So that was great.
Can I just ask you a question? I
Yes.
just took a rabbit in with a whole bunch of crusty stuff around me. It's in the hospital right now while I'm here. It's doing well. Is that what you're talking about? It looked almost like cottage cheese right around her.
So, I mean, varying degrees of,
So you're talking maybe it might be a stone?
well, I'm saying anything that causes the fur to mat back your perineal soiling, and most of the time it's not coming from the anus, the fluids, it's more urinary tract, more commonly. So, I don't know. But this is just, I think, ulcerated more than anything else, and has secondary infection because of that. So, let's see here. So we're talking about urethral calculi now, or calculi in general. You can also have renal calculi. This one is from my friend William Lewis, who used to practice in the UK. And you can open up a kidney and you can remove those. But again, not everyone is an Avery Bennett that's going to do that. You have to think about, this one had bilateral. It's just one of my cases, but you have to figure it's a bilateral, okay? So it's in both kidneys, and you have to determine what's the kidney health. Are you going to push them into kidney failure if you go in there and do that? You know, that's a possibility. So this animal is actually maintained long-term with fluid therapy, analgesics, antibiotics as needed, and nutritional support.
In people, they sometimes do the ultrasonic thing.
Lipotrypsy to try and break them down.
Do they ever do that?
They do that. They do that in animals. They have trucks that go along and do that. But when I listen to those things, I find, I mean, I am a surgeon. I'm not a Avery Bennett surgeon, but I am a surgeon. And, you know, sometimes, I don't know if you can break these down that they're going to pass the urethra. I mean, it's not very big in a rabbit. They get stuck in there, and then you're in a worse spot, you know? So in general, urolithiasis treatment, ruling out underlying infections, so ideally getting a sample directly from the bladder, doing a cystocentesis, which means we stick a needle in the bladder and pick out a sterile urine sample, so it's not been contaminated by the urethra or the perineum that's all soiled, and look for bacteria, and if they're there, ideally culturing it again. Fluid therapy, pain management, things I've already talked about, surgical removal. I also agree with Sue that calcium levels in the diet calcium doesn't influence recurrence of this problem in the rabbit. I don't know about the guinea pig. In the guinea pig, they can recur in as little as 3 weeks, which is really sad. In the rabbit, you try to rent. I think really fluid therapy. Fluids, whether it's fluid therapy, I mean oral fluid therapy. You guys pushing fluids on these animals so that you're flushing the bladder through. We do that with cats. We don't have all the answers on cats' urinary tract disease. Many times fluids to just flush out and get the things not sitting in the bladder, minerals and sitting in the bladder that are going to form a concretion or stone. If you just keep flushing through more fluid, whether it's wet vegetables or syringe feeding or adding items to the water that might make it a little more palatable. But also what can cause that perineal soiling we talked about is an animal that really is affected with echinoculi. Could have neurologic problems in the back, therefore can't clear its perineum, can't bend back any longer to our old rabbit with arthritis. They can't bend back to clean up the urinary tract, but it could also have echinoculi, and that can affect both the kidneys and the nervous system, as we all know in this room. So this paper, this is just some quotes. These are microsporidium or protozoal spores that are treated in the urine in large numbers up to 2 months post-infection, and then they survive outside the host for 6 weeks, and then the rabbit picks them up and reinfests. The literature repeatedly states, shedding of spores is essentially determined by 3 months post-infection. I put question mark, question mark, question mark. Because you always wonder, how come I've had my rabbit for 10 years, not exposed to any other rabbits, and all of a sudden you're diagnosed with echinoculi? And we'll talk about that. But I've also had a paper that wasn't referenced that from a respected colleague that was giving a lecture, and it was really from the proceedings, not a paper, but the proceedings, and he said they were shed intermittently. Does anybody have any opinions on spores being shed intermittently, or any opinions whatsoever? So, so most immunocompetent rabbits develop chronic subclinical infections in a balanced host-patient relationship. So again, they can get into the nervous system. Again, the body walls them off, and in the brain or the kidneys or other areas, the eyes, they can cause cataracts, and then the body keeps them in that sort of state of walled offness, let's say, and they're not causing a problem. Then the immune system is stressed from age or disease, and then they break out and cause inflammation, cause these diseases. Yes?
Not so much about echinoculi, but on the two-sides babies you had incontinence.
Right.
How do you know if a rabbit is incontinent or if the rabbit simply pees when it likes?
Well, it's soiling itself, so the question is, why is it dribbling urine? It wouldn't really be if it can't get away from the urine, or either it can't get away from it, or it has an infection that's making it come out slowly and dribble.
Okay.
So that's our job to figure that out. So it can also cause cataracts, as I alluded to. So for diagnostics, we've for years done titers. These are 2 labs that do these titers, and we're looking at the body's immune response in the bloodstream to this echinoculi parasite. And if it's high, we call it positive based on clinical signs. It's also showing clinical signs. We're not knowing 100% if it's positive. We tend to treat based on that information. And what we treat are all these benzimidazole derivatives, fenbendazole, albendazole, and oxybendazole. So we'll come back to that. But first of all, as far as diagnostics, this paper was from 2013 JPEM, looking at Carolyn Perry's lab at the University of Miami. Acute phase proteins levels in rabbits with suspected echinoculi. And they're produced, these APPs are produced in response to trauma, infection, neoplasia, and autoimmune disease. And one particular APP, the C-reactive protein she looked at, increased nearly 10-fold in rabbits with suspected or confirmed infection with echinoculi. Now, she did find out that that was neurologic echinoculi only. It didn't really fit or follow with ocular arena, so it's not a universal statement. But if you have a rabbit with neurologic suspect echiniculi, maybe the University of Miami lab could be a little more definitive in helping you make a more definitive diagnosis. Now let's look a little bit at benzimidal toxicosis in rabbits, 13 cases. So, you know, you've all on the lists heard periodically about rabbits who are getting albendazole and then acutely getting sick and dying from that. And that's because it has been incriminated in any of them, really, but most out of these 13 cases, I think 12 were albendazole. One was fenbendazole, one was oxybendazole. And there was evidence, the animals were getting this for echiniculi, and they came in acutely ill and had bone marrow aplasia. The bone marrow shut down, all the cells in the bone marrow were being killed, and the intestinal tract, where the cells reproduce rapidly as well, were being destroyed, and these animals were coming in with enteritis, anemia, and bleeding out because of low platelets, and they were septic, infected throughout because of low white counts. So the take-home message from this is that when you're watching and with your bin dispenses, just monitor rabbits carefully for worsening, get them in right away if you notice anything. You know, 13 cases out of all the rabbits that have been used with this is not a lot, but it happens, and you all hear the buzz about it.
So a study late in 2007 showed that 2/3 of rabbits who showed no clinical symptoms for EC tested positive for the antibodies, and some of them at a clinical level.
Right.
And so it makes me question the value of that particular test. PCR, I think, is unquestionably the better one, but it brings into question the course of treatment, because a lot of times people will give the benzoles to these animals, but not an antibiotic, and they don't look at, you know, the nystagmus, whether it's horizontal or vertical, to try to distinguish whether it's bacterial or protozoal.
So the comment is that, you know, we have a rabbit with a head tilt, you know, some people are jumping on these drugs right away, and if you do it titer and it's positive, again, the positive titer means exposure, it doesn't mean infection. And why aren't antibiotics being used, or is that not being more critically evaluated? Now, I certainly am taking radiographs to look at the osseous bulla to see if there's any evidence of fluid. If there's fluid in there, I would think more infection. You're doing a good look down there to see if there's infection. I agree, we don't always know 100%, and we can't always differentiate that.
One of the labs does the titer where they look for IgMs and IgGs, and doesn't that give you a better idea about whether it's acute?
I don't really know that answer, to be honest with you.
The IgM is telling you it's a recent infection. You get an IgM, it's going to be in the first 4 weeks of an infectious series, then the IgMs convert to IgGs. So all that's telling you is that the infection is that the exposure has been recent. That's the only thing you get.
Exposure or infection.
The response to an exposure has to be recent because you still have IgM. It's a transient immunoglobulin that only shows up in the first 3 or 4 weeks.
After exposure.
After exposure.
So that would give support to spores being passed intermittently and being re-exposed versus it always being a case where the animal's had this disease for years and hasn't been re-exposed, and then all of a sudden.
No, let's get that straight. If you have got an animal that's been chronic that has an echiniculi for years, has a titer, that will always be IgG. If you have got primary exposure, you will have an IgM response. That IgM response will be good for about 3 or 4 weeks, and then the IgM will convert to IgG.
IgMs have the naive responses, and then they transition to IgG, which we know.
So all that's telling you is a time course of the exposure, which is within the last 3 or 4 weeks. So that's what that's what you can get out of IgM type. That is absolutely new primary exposure.
Thank you. I need to move on. I'm never going to. Is that okay if we move away from echiniculi? Otherwise, I won't get to any other topic.
When you say exposure, do you mean to a new rabbit, or just, I mean, like you were saying about recurrence versus?
Right. Again, is it a new rabbit? You know, the spores don't live that long outside the environment, so you wouldn't think it would be. You would think it would have to be a new rat, or unless the rabbits you have are shedding these intermittently. That's the question that we don't have the answer to, unless, do you know the answer to that?
I don't know the answer, and I'm wondering about fomite transmission.
Yeah, I mean, it can be seen in guinea pigs too, or, you know, fomite being things you bring in, but I don't know. You have to, you're dying to answer.
I just want to tell you, I have a study from 1988. Several hundred rabbits that investigate then many of them with oxygen, like vitamin A. Just the same thing of the dress published in 2003, but for EC, not for the
Thank you. Yeah, I'd like to send you that.
Unfortunately, it's all in German, there's like 10 pages summary.
I'll take the summary in English.
But if you can tell me which pages you want translated, I'll do that, but I'm not going to translate one.
Okay. Well, I'm running out of time, but am I out of time? Probably. A minute. Okay. Indolent ulcers. So let me just talk about this. Corneal ulcers that don't respond to common antibiotics. That's what an indolent ulcer is. So we diagnose an ulcer on the eye and the cornea by staining it, and when anything interrupts the superficial surface of the cornea, that stain will stick to it. And sometimes we do treat these with antibiotics and anti-inflammatories sometimes, and then something to reduce pain. And we reassess them to see if they've healed. Sometimes they come back and you see the same thing. It only gets to a certain spot, and those last few cells can't cover that ulcer up, those last cells from the cornea that are creeping across and closing that ulcer up. And they're called that makes it into the ulcer. And if you would take a cotton swab and just gently peel it back, and you see that superficial layer just peels right back again. So what you need to do is excoriate that. It's kind of like hanging a hook on a tile in a bathroom. You need to excoriate that tile before you can get that hook to stay. And so this just was a tip. This algae brush by Wilson Ophthalmics is this very gentle diamond burr that's very fine. It sounds bad, but what we used to use is a fine needle and cross-hatch that cornea to get that to grow back. And now we use this. So here I'm taking that, and it's a little motor, and it spins around, and it gently debrides that, but it gives those cells something to grab onto. Okay. I can stop there. Stop. Okay. Okay. Thanks.